What is urinary incontinence? Urinary incontinence is the involuntary loss of urine. The two major types of urinary incontinence are stress and urge incontinence. Stress urinary incontinence involves the loss of small quantities of urine during an increase in intra-abdominal pressure, which is produced by coughing, sneezing, laughing or exercising. SUI is characterized by outlet incompetence. Urge urinary incontinence involves urine loss due to abnormal diffuser muscle contractions and is, to some degree, associated with urinary retention. UI is a major component of overactive bladder syndrome, and is characterized by an abrupt and strong desire to void. Other types of urinary incontinence include overflow, functional and mixed. Overflow incontinence involves a variety of symptoms such as urgency, frequent urination and constant dribbling, and is characterized by urine loss due to overdistension and ineffective emptying of the bladder. Functional incontinence refers to the inability to get to the toilet in time due to acute or chronic physical or mental impairment. Mixed urinary incontinence is the term used to describe the condition in which the symptoms of both SUI and UI are present. Reversible causes. Delirium. Results from medical illness or medication. Incontinence is secondary and abates when the cause of delirium has been corrected. Urinary infection. Atrophic urethritis may cause or contribute to incontinence. Vaginitis responds to topical estrogen therapy. Pharmaceuticals. Many drugs can cause or contribute to incontinence, for example anticholinergics, CNS depressants, sedative hypnotics, alpha-adrenergic antagonists, alcohol, diuretics and caffeine. Psychological. For example cognitive impairment. Excessive urine output. Results from a large fluid intake, consumption of diuretic agents, metabolic disorders. Nocturnal incontinence may result from the mobilization of fluid from peripheral edema. Restricted mobility. Often results from overlooked, correctable causes such as arthritis, postural hypertension or fear of falling. And lastly, stool impaction. The two most common causes of urinary incontinence are urinary tract infection and constipation. Who are at risk? Patients at high risk include the elderly, especially menopausal women with a history of pregnancy and childbirth, medical conditions such as chronic cardiac disease, diabetes mellitus, hypercalcemia, chronic lung disease, constipation with fecal impaction, neurological conditions and cognitive impairment, or other disabilities affecting mobility. Is urinary incontinence a natural aging process? Although urinary incontinence is more common in the elderly and female populations, it is not part of the natural aging process. If untreated, it can lead to skin irritation and worsen bed sores. The condition is a common source of social embarrassment. This loss of control can damage self-esteem, result in anxiety disorders or even lead to major depression. The care required for an individual with urinary incontinence can increase the caregiver's burden. What can my practice do? Actively screen high-risk patients. Clinicians can screen high-risk patients for symptoms of urinary incontinence. Depending on the patient's duration and severity of symptoms, as well as predisposing risk factors, the consultation can progress to either identify reversible causes, or discuss further investigation and management options. Quick surveys on how the patient or caregiver is coping with the symptoms are equally important. The impact of the symptoms on the patient or main caregiver is an independent and overriding reason for definitive care, even when the condition is clinically early or mild. Take a dietary history. Clinicians can encourage patients to keep a simple dietary diary that records the total amount of fluid and bladder irritants, such as caffeinated beverages, chocolate, alcohol, acidic fruits, tomatoes, sugar, spicy foods and carbonated beverages, consumed within a 24-hour period. This diary can be reviewed together with the patient in order to jointly identify areas of change and decide on lifestyle modifications. Review medication records. A review of the patient's current prescription medications should be done. Medications which may worsen incontinence should be reviewed for their indications, and the introduction of a substitute considered. Some useful investigations. Clinicians need to conduct a general examination of the patient, as well as examinations of the lower abdomen, genitalia or perineum, and lumbosacral spine. Through these examinations, common causes of urinary incontinence can be excluded. Most primary care setups are able to perform simple urinalysis to exclude urinary tract infection. A basic serum check for renal function can be considered. Patients with repeated urine samples that contain traces of blood or persistent abnormalities will need to be referred to a urologist. In and out urinary catheterization can also be conducted in the clinic within 5 minutes of voiding to assess post-void residual urine volume. A PVR urine volume of more than 150 milliliters indicates incomplete emptying of the bladder, and a PVR of more than 400 milliliters is likely to be indicative of overflow incontinence. Alternatively, the patient can be referred for urodynamic studies. Non-pharmacologic therapy. Simple dietary advice, such as limiting caffeine intake, can be offered to affected patients. Other useful dietary pointers include adequate fluid intake to prevent constipation and concentrated urine, which can potentiate the irritative effects of dietary materials. Excessive fluid intake may be suspected if the recorded intake in an adult grossly exceeds the typical daily requirement of 1,500 to 2,400 milliliters. Restriction of fluid intake an hour or two before bedtime is usually effective in reducing nocturia. Behavioral modifications that can be employed include bladder training, prompted voiding, and scheduled toileting. A voiding diary can be issued to affected patients or their caregivers to document each void and episode of incontinence daily. This diary can be reviewed at the next consultation to characterize the type of urinary incontinence affecting the patient. Pelvic floor exercises such as daily Kegel exercises can increase the strength, control and coordination of pelvic muscles. These exercises are most effective in women with SUI. House calls can be offered to patients with functional urinary incontinence, focusing on the patient's ease of getting to or using the toilet at home. These home visits can help the patient's family decide on changes that may improve living conditions and optimize the patient's urinary incontinence management. The best prevention for urinary incontinence is healthy weight management. Maintaining an optimum weight may decrease urinary incontinence, secondary to decreases in pressure exerted on the bladder and urethral mobility. Pharmacologic therapy. Pharmacologic therapy should be used in conjunction with non-pharmacologic therapy. Pharmacologic options for stress incontinence. Localized estrogen replacement therapy may be considered if menopause or other relative estrogen deficiency is identified as the main cause of urinary incontinence in females with SUI. Topical estrogen such as vaginal estrogen may be inserted as a pessary every 3 months. Alternatively, an estrogen cream can be applied 3 times a week. Pharmacologic options for urge incontinence. Anticholinergics are recommended as the first-line pharmacotherapy in the treatment of urinary incontinence. Tolurodine and doxybutynin are considered standard therapy, but tolurodine can be first considered for use as a muscarinic receptor antagonist, as it has a higher selectivity to bladder receptors and a lower incidence of adverse effects.
Audio Jungle. Audio Jungle.